Dr. Reuben, now that we understand more about how the components of care are reflected in the health delivery services system, we would like to talk about dementia care policies and models.
Sure.
We wanted to hear about how the work you have done may influence national policies and programs for dementia care.
Yes, and I would like to say it's not only the work that I've done, and it's not only the work that our team at UCLA has done. There are a considerable number of people working on this. There are other models that are also very, very effective. But we are working to address a major deficiency in healthcare. If you take a look at practices of physicians' practices, and we've actually done this, and look at the quality that people who have dementia are receiving, it's like 20% of quality indicators are met. Okay. And that's not good enough for our parents and grandparents. And there's no way of covering this. We have spent a lot of time locally because the program is quite large. We have over 900 people in the program, is trying to get it to pay for itself. And we lose a lot of money. Every patient we lose money on. So we've actually, a great tribute to UCLA, its Department of Medicine, the health system have subsidized the program. But it's exceptionally difficult to disseminate it. And we've been working on that through through support from the John A. Hartford Foundation to other programs, because it's a loss leader. They lose money doing so. So the timing is really right for Medicare, and in particular, we've been speaking with CMMI, Center for Medicare and Medicaid Innovation, to think about a different way to pay for this, because the current policies just aren't working. And they have shown a good deal of interest. They've shown a good deal of interest. And in fact, fingers crossed, there will be a demonstration project, at least at some point within the next year or so. But right now it is a huge gap. And I have to tell you, I have to give you a quote from Nancy Reagan. When her husband was diagnosed, she said, we had nobody to turn to, nobody to answer our questions. And really, for most Americans now who have dementia, we have nobody to turn to. And it was 6.5 million people with Alzheimer's disease alone, plus those who have related dementia. This is a big problem. And baby boomers like myself are getting older and will be developing dementia. So that number is going to increase. And just as there's a lot of enthusiasm about drugs for people who have very early Alzheimer's disease or early MCI due to Alzheimer's disease, there's a lot of enthusiasm for that. We have to mount the same kind of enthusiasm for caring for those people who won't benefit from those drugs, because the vast majority won't. Their disease is too advanced.
Dr. Reuben, at what point did your work go beyond thinking about improving a single model of care at UCLA, and did you start thinking about how to scale this up nationally?
Thank you. Well, from the get-go, I had always had visions of working with people to create an innovation that was would extend beyond the confines of UCLA. The idea was to create a model that could be effective and replicated. However, the big turning point was when our Center for Medicare and Medicaid Innovation, Healthcare Innovation Award had positive results. Comparing the people who participated in our programs to a matched control group, people who looked like our patients, but didn't receive that care. It actually saved Medicare money. It saved them about $2,400 per person per year. And it did that, primarily by reducing hospital days, and there were shorter hospital stays. People were able to be discharged quicker, and reducing long-term nursing home stays, placement, because families couldn't take care of people at home anymore. And it also increased hospice use. People were better informed and better in touch with what the person living with dementia's wishes would be if they found themselves in this kind of condition, and a marked increased use in hospice. With that, we kind of immediately began thinking about expanding the program both locally and extending it nationally. And around that time, the John A. Hartford Foundation was very supportive of the work and has helped us spread the program to now 18 sites that are delivering UCLA's model of dementia care. We took the name UCLA off. It's just called Alzheimer's and Dementia Care, because we figured that a lot of health systems don't want to advertise UCLA, but the program is intact all around the country.
Huh. And you mentioned 900 patients. Is that 900 just in your site, or is that the 18 sites altogether?
The 900 is at UCLA currently. Okay. We've seen about 3,600 people locally since the program began. And I think about 6,300 people have been seen nationally since. Recently we switched over that more people were receiving this care outside of UCLA than at UCLA.
That's definitely a milestone. What did you learn over the years from the models you were working on, and how have they evolved over time? I'm sure there were things that you learned worked, and you talked about that a little bit before. And what specifically did you learn from the Healthcare Innovation Awards, the HICIA evaluation that CMS did for the UCLA Alzheimer's and Dementia Care model, and how did you improve the model based on some of the lessons that you learned?
So we did learn an enormous amount from the CMMI Innovation Challenge Award. One of the things we learned was a lot about what a caseload or panel that a dementia care specialist could handle. And originally we planned 250 persons living with dementia and their caregivers. But every one of the dementia care specialists, when she has hit 100, she kind of hit the wall. And we realized, fairly early on, if we were going to have the advanced practice provider care for that size patient load, we would have to get some help for them. So we have we hired what we call a dementia care assistant to help the dementia care specialist. And by helping them, one of the things they do is they make the calls to the green patients and then triage them. So as the program has gotten bigger and as we've gotten more very severely affected patients, we've had to provide more support. And most recently, last summer, we added a social worker to the program. And that also has been exceptionally valuable. So, it's kind of every person on the team has a place, and we work very well as a team, and it's great. The one person who they never see, the one professional they never see in the program is a physician.
Really?
Yeah, it is a nurse practitioner led, and the physician in the program is the person's primary care provider or a specialist. And that is what we call a partnering physician. So this is not to replace primary care, it's to help primary care and help neurology and help psychiatry.
So do you participate as one of the care providers in this plan, or are you supervising all these nurse practitioners and overseeing?
I am responsible. We have a medical director, and currently I'm sitting in that role, the medical director, as well as director of the overall program. But the medical director can provide guidance on individual patients. Every Thursday, we have a conference where the dementia care specialists present their most difficult patients to the team, and I'm at those meetings, and they're tough. These people, there are no easy solutions for many of these patients. Yes, but the work of the program is primarily done by the nurse practitioners, and they get so good at it. They're so good.
That's really fascinating. Dr. Reuben, thank you so much for sitting down with us today. It's been a pleasure speaking with you. For more information on RTI's expertise in Alzheimer's disease and related dementias, please visit us at rti.org.